Okay, next up we have endoscopic findings and outcomes of revisional procedures in patients with weight recidivism after gastric bypass. This is going to be presented by Dr. Yimcharoen from Cleveland Clinic.
Good afternoon, Chairman. Ladies and gentlemen, I would like to thank you for this opportunity to present this study. I have no disclosure to make. Follow-up gastric bypass patient has demonstrated that significant weight regain occurs in 10 to 20% of patients in a medium to long-term follow-up. This phenomenon of weight regain is thought to be the multifactorial and combination of anatomical, behavioral, and psychological factors. Furthermore, it is not certain if pouch and stoma reduction restore efficacy of bypass procedure. This aim of this study was to investigate the gastric anatomy of patients who regain weight after room-wide gastric bypass. We also wish to determine the outcome of revisional therapy in the patient with abnormal gastric bypass anatomy. We undertook a retrospective review of our prospectively maintained surgical endoscopy database to identify all patients who underwent upper endoscopy for weight regain after gastric bypass between July 2006 and August 2010. We also identified those patients who proceed to undergo revisional therapy to reduce the size of gastric pouch and/or stoma. Abnormal post-gastric bypass anatomy was defined in this study as a gastrojejunostomy diameter more than 2 centimeters and/or dilation of gastric pouch more than 6 and width more than 5 centimeters. In our case, the surgical endoscopist measured gastric pouch and stoma dimension using an articulating measuring instrument, which was introduced to the working journal of the flexible endoscope. This revision cohort was arbitrarily classified into 3 groups according to the interval between their current presentation with weight regain and their gastric bypass. Regain weight was defined as a weight gain after reaching one's nadir following gastric bypass. The outcome of revisional surgery was assessed using the percentage of regained weight loss. I have now presented our finding. 205 patients were included in this study, all of whom have presented to our unit for investigation of weight regain after gastric bypass. This table demonstrates the baseline characteristic of these patients after a mean interval of almost 20 years from the gastric bypass. This patient regained an average of 60 pounds from their lowest post-bypass weight, resulting in a BMI increase from nadir of approximately 10 kilograms per square meter. Here are endoscopic findings in this patient. Almost 3/4 had abnormal finding upper endoscope. As you can see, the commonest abnormality identified was dilation of the stoma, found in almost 59%. Dilation of both pouch and stoma was observed in 18 patients. Weight gain, the greatest among these patients, had an enlarged stoma as the single anatomic abnormality. 51 patients underwent a revision procedure, including 30 patients who had a laparoscopic surgical revision and 21 patients who underwent endoscopic revision, as detailed above. After mean follow-up post-revision of 13 months, this group overall achieved a mean regained weight loss of 60%, comparing mean percentage of regained weight loss according to time from the gastric bypass. Percentage of regained weight loss was the highest among the patients in the group 1 and the lowest in the group 3. The difference in percentage of regained weight loss between 3 groups did not reach statistical significance, although could trend toward greater weight loss with shorter duration from the gastric bypass was observed. In conclusion, we believe that endoscopy is a valuable tool for evaluation of weight regain after gastric bypass surgery. It can identify abnormal post-gastric bypass anatomy in the majority of patients which likely to have influenced their weight regain. Prompt early intervention may yield the greatest benefit in addition to ongoing appropriate post-bariatric surgery follow-up. Revisional procedure to restore normal gastric bypass anatomy appear to be more successful if performed within 5 years of primary procedure. Thank you for your attention.
Any questions? First question I have for you is, you measured the stoma, you measured the length of the pouch to determine dilatation of either one of those. How were these pouches created in terms of how were they calibrated to a certain size at the initial operation?
No, we don't know. We don't know actually of the primary procedure because this patient, we look at just only endoscopic, so just in the data in ours, and all patient we measure during after weight regain like that, but we don't know exactly what from the primary procedure, maybe more than 10 years.
I guess the question is for the patients that you're classifying as pouch dilatation, how do you classify it if you're unaware of what the starting size was?
In our study, if the pouch is length more than 6 centimeters and with more than 5 centimeters, we call that dilated pouch.
Okay. I don't think you probably have that information, that what the initial pouch size was after it was created, so probably unable to come up with that information at this point, but it'd be something to look at if you look back. I'm assuming all the operations weren't done at your institution, the initial operations, or were they?
You mean
The first operation?
the first one? From other institute.
Okay. First, Mike.
Mark Pleatman from Detroit. I also see a lot of people who regain weight, and my question is, how do you determine what's abnormal? You're just saying this is abnormal, but have you scoped a bunch of people who are doing great and measured the sizes of their pouches?
Thank you for the question. This study, okay, we did this study. We start to look at the stoma and side pouch of stoma or side that affect for weight regain or not, and then so we don't know exactly what is a normal gastric pouch or stoma. Sometimes we think that stoma is less than 1.2 centimeters. Okay, it's a great outcome, but we don't know exactly what should it be. So this study, we just categorize in the patient. If we measure stoma is more than 2, with that, big stoma, and if the pouch is more than 6, we call that a dilated pouch. Just that.
All right. I do have one question. So were all these anastomoses of one type, were they all circular? Were they some side-to-side linear staple, some hand-sewn, and some circular, or were they all the same type of anastomosis?
We don't know. We don't know exactly what it was, but we know just that they run one gastric bypass. We don't know that they use a stable linear or circular.
You probably have enough data to come up with whether one actually is more prone to dilation over the other. Just if you could find out how the original anastomosis was done, side to side, linear stapled, circular versus hand sewn, and see if there's a significant difference between those groups. So, in the interest of time, I guess we should probably move on.
Thank you very much.
Thank you very much.
Thank you very much.